So I'm not gonna cover it for smokers? How am I gonna get that information when it comes to the health plan? So how do you write that policy to cover it for those groups that it really says, you really ought to think about covering it? So that's some of the complexities that we have to deal with. The other thing, it was brought out, a couple other people said, well, this is pretty complex, this isn't as clear cut and dry as you think. How are PCPs gonna understand this, and what are they gonna have in their discussions with their patients? And it's one of the things for those of us who spend a lot of time doing this and sit around, but these PCPs are dealing with a lot of other stuff besides just heart disease. So how are they gonna figure out what they should recommend, what kind of conversation they have with their patients, and how they're gonna do that? The last part, if we say yes, it's medically necessary, it would go for this particular population, then we look at the cost effectiveness. There does seem to be some good data in a subset of populations that seems to be very cost effective. The two caveats would be, what is the cost of the test? And I heard numbers $1,500 for the screening test. When insurance starts to cover a test, and what happens to that cost?
It's $150. It's standard.
$150.
But it's way more than that in a lot of places.
Right, so what's gonna happen when the insurance company starts to cover it? Is it gonna be $150 still?
And the statins are all generic.
And the stats are generic now, right? Right, so when you start thinking about that, great, it'd be great if it was $150, but when we cover it, I don't think that's what our contract, folks trying to negotiate a contract for, that's not how it's gonna work out. So it may or may not be cost effective in the long run, depending what the cost of the test is. I am definitely intrigued on the improvement in compliance. That is something that we wrestle with all the time, putting on my Right Care initiative hat. Right, we think about health disparities, and we think about how we motivate people to do the right thing. And so that is something I think would be a key part also. And with that,
I have one little question for you about San Diego before we move to Dr. Carol Zaher. And that is, one of the things that we did there to achieve the 24% reduction in 4 years of AMI hospitalizations is that we optimized medication therapy management and titrated up the dosage to fit the condition. So where you said, where there's family history, we're not gonna cover it. If you have family history and you have a score, like I have a family member that has a score of 1,760, then you're gonna wanna go for the much higher intensity, not for the 20. So that's where I would think it would be very handy for titrating your dosage.
that's not how I read the AHI guidelines that said they should be on high intensity statins and they should be on it, and it's a no-brainer.
For family history, regardless of score?
That's what the guidelines actually say, so. And how do you gather that data as a health plan and use it when you get the submission for covering the test? They have to check little boxes, yes, they have the family history or not, et cetera, and it becomes complicated and time-consuming at times,
So since we're in Silicon Valley and we have so many IT people who are very savvy, we have been thinking about ways of automating things, and I think that
would be wonderful, and we're working on ways to do that too. Everyone should also be aware, we also sit on the California Quality Collaborative, and I'm not sure everyone in this room is aware, but 30% of California physicians still are not on an electronic health record. 30% in this state. Okay, so you think it would be easy when we sit in the land of the Apple Watch. You see what I have, right? I have the analog one. So you think it'd be easy, and it's sometimes not. So when we work on how we do our criteria for approving things, we need to make it easier for physicians to know which boxes to check and get things fitted in. And we're actually actively working on trying to make that easier.
So I can make your job a little easier, because Medicare in the state of California covers calcium scoring, and they pay about $99 or $98 from year to year. It changes by $1 or $2, but you have a price point at least, so you don't have to negotiate that too much, and that's probably a reasonable price point for a test that takes only minutes to do. And I know people who own the machines would like to get a lot more, but I think that works, and it's been in play for about 10 years, that approval. And they have a triage, they call it a triage tool. They don't call it a screening test. They call it a triage tool for statin or for lipid-lowering therapy. They call it a triage tool for lipid-lowering therapy, to get away from the word screening, because Medicare doesn't cover screening. So they've gotten around the language issue as well, because we don't want to step on Doug's toes there, start talking about screening, because that's his domain and not your domain. But they also have age criteria, and I know Medicare's older already, but they have age criteria and risk factor criteria to qualify for a calcium score. So I'm not saying that it's easy and that you can just adopt that, but some of those questions have been answered and have been in play for a decade, and I think work, although again, our target population is not the typical Medicare patient. It would be the Blue Shield of California patient.
Absolutely. And I'm not saying those are insurmountable obstacles, those are just considerations that we have to take into account. What are our administrative costs or anything we're covering to make it worth our while to cover? Because sometimes, if it costs too much to review something, we just don't review it. It's not worth our while to do it, and then you just leave it up to the physicians to check the right patients, and then here we go again. All of a sudden, I got a 19-year-old get a coronary or a calcium score, right? So, other questions?
Continue.
Carol, thank you for putting those slides together while you were on a cruise.
Yeah.
She is so dedicated. She is a cardiologist, interventional cardiologist, before she moved into being a medical director at HealthNet, and she helps me chair Los Angeles. So she's
Thank you.
gone out of her way to.
Yeah, Hattie asked me 3 weeks ago if I could present something from the payer perspective, and I must have had a lapse of consciousness because I said yes. So I got this together, and then I got back from vacation, and lo and behold, guidelines changed. So, so I'm going to include those at the end of the presentation. I slipped in a few slides for that. And I realized most of what I'm going to say, the majority of what I'm going to say, is actually already been said and has been covered. So you won't have to sit through too much, just a little bit of redundancy. I don't have any things to claim as conflicts of interest, but I do have a disclaimer very similar to Doug's, that when Hattie asked me to represent the payers, I remember the last time I did that was for the ACC in the 90s, and that didn't go well. So I am not able to represent all of the payers or all the health plans. And what I'm going to give you is Carol's perspective on the health plan's perspective. So we're going to go over just a little bit of historical stuff, just to sort of put into place what the foundation of a health plan is, how we develop guidelines, although Scott basically covered all of that for me. Thank you very much. And then I have a few examples of some health plan guidelines for coronary artery calcium as of 3 weeks ago. So let's go through that. Again, this sounds odd, but health insurance began in the 1850s. I didn't realize that. So for 100 years, we've been basically a fee-for-service, risk-sharing and spreading type of organization to cover costs of health care, just like your auto insurance and your house insurance. Then somewhere in the probably the 1960s, managed care started to take place here in California. We know it mostly as Kaiser, but I think the Mayo Clinic actually preceded them. And you know, up until the 50s, there really wasn't a lot being done in healthcare, so there wasn't a lot to approve or disapprove. Treatments were very limited, so fee-for-service reimbursement worked well. Then somewhere after the 60s, 70s, certainly after that, we really took off in medicine with a lot of complex, especially more recently, really complex care and procedures, et cetera. And then we got the impact of quality care initiatives, performance standards, and evidence-based medicine came in, and as Paul said, it's still evolving. So at the health insurance industry, we're in the middle of that, and how do we pay for it, and how do we deal with populations to give what's the right care at the right time for the right patient, right, Hattie? Medical necessity, again, that's been bandied around. We look at procedures, tests, whatever, as opposed to not medically necessary. We cover anything that is medically necessary according to standard definitions, although that can be somewhat argued as to what really the definition is. And I'm not going to go over it because of time, but you're all very well aware of that. Obviously, evidence-based medicine, as we've discussed, we look for outcomes, we look for treatments to be really effective, and that's the basis of what we cover and decide is medically necessary as well. As I've been involved with several plans, more than a handful, either consulting with them or working for them on medical policy development. And in general, I'm going to say, you know, as a whole, we use basically what Scott has said, and we look to you in the scientific community, and the guideline community, and the societies like the AHA and that alphabet soup, the new guidelines, and the U.S. Preventive Task Force. We look to the outside world for what are you telling us? You know, rather than trying to duplicate a lot of the work, we look for guidance from you. And as you can tell from the last discussion, as Dr. Sidney said, it gets a little complicated, certainly not only for the average patient out there, but even for some of us in health plans to figure out what we really should be doing that's in the best interest of the patient and society as a whole. So we look to national guidelines, society, the AHA, et cetera. We're talking about cardiology here, ACC, lipid societies, et cetera. We also look at third-party guidelines, HAYS, the former, I guess, Blue Cross Blue Shield Tech Committee, Interqual. Some organizations will use Interqual guidelines, and they do have guidelines for calcium, coronary calcium scoring. They're very simple, actually. Got Milliman, their imaging vendor guidelines. Some of the health plans will not do their own policy development for certain procedures and tests, but they'll use a vendor, and there are imaging vendors out there, the old Med Solutions, now Evacor, NIA imaging guidelines, and so if the health plan uses a third-party vendor, they'll often use their guidelines, or they will sort of adapt that agency's guideline to meet their needs. We look at published literature, we look at external specialty review, we'll ask the Dr. Budoffs of the world what they think. And then there is an internal policy committee review. So we try to take all of that that's out there and put it into some semblance of a guideline that is easy to assess what we want and what we're asking for. And that tends to hopefully be evidence-based, outcomes-based when possible, and in accordance with what's happening in the real world out there. It's not always an easy or a well-defined process, but we try to go through it in an order that seems to make sense for us from what you guys are saying out there in the real world. This was just, again, a Blue Cross Tech Committee from a while ago to talk about the guidelines for how they develop guidelines. And again, well, you can see this online. It's going to be on the site, isn't it, at some point, the presentation? So you can read it.
All the slides will be posted. Yeah.
Right, because I don't want to really get into too much detail here, but you could look at what the guideline development policy was for that tech criteria in the past. HAYS, again, a lot of HAYS, they do an ABCD criteria base where A is good and D isn't, basically. And one of the problems with HAYS to me is that they're a little behind the time. They're not as up to date as some of the other guidelines that we may look at. This you've already seen, that on the left there, the AHA-ACC guidelines, these were from the 2013 article, which is now old and a little bit outdated for calcium artery, coronary calcium scoring. And then the recent preventive services guideline that Doug just told us about. So we look at especially these types of guidelines to help us sort out what our guidelines will be. We look at the literature. Again, this has all been discussed so far, that yes, coronary or calcium is specific for coronary atherosclerosis, has an impact on outcomes. The question of, is it clinical outcomes? Does treatment defined by CAC really prevent death and events? That's a little bit up in the air right now. Risk versus benefit, again, very little risk to the calcium test. Versus statins, probably very little risk there as well. So, we're looking at all of the things that everybody said so far. And again, cost effectiveness, a little bit controversial, although the cost effectiveness of actually doing the test seems to be pretty beneficial. But is there a cost benefit analysis in the final outcomes? That's the kind of information we'd like to have. I'm not sure if we're going to get that. And then there's this in the middle grain here, this proposed guideline, which is probably now the guideline, which I'll get to in a little bit. But it seems to be focusing on this intermediate risk group. And again, that's not going to answer the problems of maybe the 1 in a million or the 1 in 1,000 patient that we're not going to pick up by doing this. But all the evidence that I've looked at least recently, seems to be focusing on this intermediate group. There was this.
Could you back up a slide and just read that last statement that you spent so much time on, perspective?
The perspective, okay. Perspective. The suggestion that statin therapy is not recommended when 10-year ASCVD risk is less than 5%, regardless of calcium, coronary calcium, ignores a cohort in whom calcium scoring is often considered, that being in pre-45-year-old adults with well-characterized premature coronary disease, strokes in the family, and risk factors such as low HDL, isolated very high LDL, and elevated lipoprotein. So yes, it will miss that group.
And that's based on your career as a cardiologist. This is your perspective.
Oh, no.
No, what perspective? Sorry.
This came from, I think, Greenland.
Oh, Phil Greenland.
No, that wasn't my perspective. Sorry. No, these are all direct quotes from that. And this is the 2018 slide. That's in the article from Greenland, and it talks about what Matt was talking about. Their reclassification. Is there a benefit to using the coronary artery calcium score to reclassify this intermediate group, however you want to define an intermediate? So again, if you look at the again, using the traditional risk scores, the less than 5% risk group looks like it's not really effective for that population. If you look over on the right, the greater than 20%, it doesn't look like it should be effective for that, because you're definitely going to be treating that group. So then you've got the middle group, and there, you can argue what is really intermediate. But if you look at 5 to 7.5 versus 7.5 to 20%, that there, if you use a calcium score, which is in the left-hand column there, and if it's 0 in that intermediate group, then you wouldn't recommend treating aggressively. Whereas if the calcium score is greater than 0, then you would either consider it or recommend, depending on the level of risk. So you can redefine the areas in that intermediate group. And I think, Matt had a nice slide about that. What, 13% did you say would be treated versus 60%? So for that risk group, it looks like it would be beneficial. Now, again, you're still leaving out that group that I know Hattie wants to deal with, which is a problematic issue at this point. So I liked this slide because I think it shows it pretty well graphically based on Greenland's study. I did pull out some language from health plan policy examples. I didn't want to put the name of the health plan in there to protect the innocent, but these are actually, again, these are scripted. You can just do a Google search for many of the health plans. If you're a provider with a health plan, you can actually obviously get into their guidelines and policies. But these are just slight excerpts, minimal excerpts from some examples, and these are ones that aren't covered, and the reason why. Such as, there's insufficient well-designed studies to support the effectiveness of EBCT or CAC, or calcium scoring by means of computed tomography is considered investigational for all indications based on the peer-reviewed medical literature because of lack of high-quality evidence demonstrating improved clinical outcomes or impact of treatment management from the use of CAC. They see it's investigational, and investigational items are usually not covered in health plans. There's been some evolution over the last couple of years. Here's an excerpt that says it's medically appropriate for patients who are candidate for CTA, coronary angiography, to have calcium scoring performed as part of the CTA, since pretest knowledge of the extensive calcification of the coronary segment may diminish the interpretive value of a cardiac CTA. That's pretty standard. I think if you're going to do a CTA, you start with the calcium score. But it's not done primarily for the calcium score. And then here's one, coronary artery calcium scoring is useful for risk stratification in asymptomatic patients with moderate risk, they don't define that, for coronary artery disease based on Framingham. There are obviously multiple tools one can use for that, or as a triage tool, as we mentioned earlier, for symptomatic patients to rule out obstructive disease and avoid an invasive procedure. some medically appropriate language. Again, asymptomatic persons 40 and older with diabetes, or asymptomatic persons with intermediate risk, here defined as 10 to 20%, 10-year risk based on Framingham or the full cohort. And then repeat calcium scoring, which we didn't talk about too much here, but repeat calcium scoring considered medically necessary only if the member's most recent score was 0 at least 5 years ago, and that discovery of a change would change management. And I think, Matt, you like the 5-year interval there. The issues that and I can tell you, for instance, like interqual gives you, I think, 4 different risk scores that you can use, and if it's an intermediate by any of those scores, and the patient's asymptomatic, you basically meet interqual criteria, which is a very simplistic guideline. A lot of the policies that deny it or do not consider it medically necessary or evidence-based say there's just limited evidence and there's a certain level of appropriateness. I didn't find any policies, and again, I looked at about a dozen policies, some major health plans and then some smaller ones. And medical groups, by the way, also sometimes make their own policies. So it is confusing out there, I guess, for the practitioners when you're dealing with patients from all different health plans. You're dealing with all different guidelines and rationales too. That does make it more challenging in the real world. I didn't find any policies that covered mass screening, meaning any asymptomatic patient, 18 or older. I didn't see any policies that did cover that out there. So, what are the recent guidelines? Well, again, we've already seen this with the alphabet soup there. This is number 7 and 9 in the handout that Hattie has, so you can read that at your leisure. But again, this looks focusing at the intermediate risk group. And then this, I don't know if you can see it very well, but this is the primary prevention table, that if calcium scoring is in the lower right-hand corner. So if you're an intermediate risk and you come down, but the decision is going to impact subsequent management, the calcium score is 0. You don't need to treat if it's 1 to 80. Now I don't have my other good glasses on here. Let's see what is it here. Oh, can't read that. Yes.
We should probably move to discussion.
Okay.
Sam, Carol.
Yeah, because that's basically it. So again, what I'd like to hear, we've heard a little bit from this group, is do we really need additional clinical outcome evidence, sort of more robust, like we were talking about, the endpoint clinical outcomes? Is it really realistic to consider we're going to do some of those studies? If not, what further evidence do we need to change the guidelines to get all the people on the same page? Because we seem to be on different pages right now. And does anybody have an ideal guideline or policy that they would like? Yes, Scott.
Yeah, I just have one other point of clarification on how often these policies are looked at. We review our policies at least annually. I
Yeah.
assume you do a similar thing. And sometimes much sooner if the evidence gone, like the AHA guidelines just came out, so I wouldn't be surprised if we look at it sooner than get you an annual review.
Right, and I agree. What we do is if or if I see some cases that we send out on appeals and I'm getting suggestions from scientific community opinion leaders that our guidelines are maybe not copacetic, I will actually go back to our policy committee earlier than the yearly review and say, hey, let's look at this because now I'm getting some information out there in the real world that is conflicting with our policy. Is there a reason, is there a rationale that we should be changing it or at least looking at it again? But yes, they are reviewed annually or sooner if something like this comes up.
Thank you so much. Really appreciate that. So this last section, I think we're going to have Bob Kaplan and David Marin primarily facilitate. And I think since we started 15 minutes late, if it's okay with everybody, we'll break for the reception at 7:15. Is that okay, Neroli?
Well, we'll see how the people feel, or we can continue the discussion out in the.
Yeah.
Sure. No one's gonna kick us out of the room.
But we don't want to stand between you and your wine.
Let me see if I can just tee up one question and then hand it over to David. But I think that Matt did a very nice job of persuading us using observational data from studies like MESA and others that that coronary calcium is a good test, that it provides information about probability of events in the future. On the other hand, we heard that there's a different evidence standard for translating that into, that having that knowledge about probability of an event translates into information that allows you to save lives through interventions. And for that, there's a different type of evidence that typically comes from randomized clinical trials. I know there's some debate about how much task force and others depend on those. So that's, I think, to me, the question that might lead into this discussion. How can it be that we've got a really good test, but that we still don't, we still have uncertainty as to whether or not that test results in saving of lives? David, you want to?
No, thanks. No, I think that really is, seems to be the hindrance for the acceptance among payers and physicians, is the absence of a randomized controlled trial, because that is considered to be the highest form of truth. So I think everyone in the room believes or knows that smoking causes heart disease and cancer, and that stopping smoking prevents bad outcomes. Never been a randomized controlled trial to prove that. So I would love to just hand that microphone over to Doug and ask how important is it in understanding what is true to have a randomized controlled trial?
Well, it's very helpful. It's not always necessary, as Matt pointed out. Smoking, there's overwhelming observational evidence. I'll give you an example from our past guidelines, hepatitis C screening. We spent a lot of time talking about whether sustained viral response really translates into mortality benefits. And the observational studies are compelling about that, but they're very confounded, right, with all kinds of other things. So the problem for us is that sometimes we find observational data that we feel like we can hang our hat on, and other times we feel like the threat of bias or the limitations of study design are such that we can't. And that's kind of a case-by-case thing. I don't know that any trials will be done. I think now that the ACCHA and all the other groups have recommended this, I'm guessing that lowers the probability that we'll have trial data. But it is a topic where I think you could do trials if somebody was willing to fund them and wanted to do them. But I don't know that we'll see that. So I'd say from our approach, it's sort of there are things like smoking where we think the observational data is so overwhelming, and other topics where the observational data is not enough.
One quick comment, and then we'll open up.
Yeah, Stephen wants to speak, and I'm actually very interested in hearing his perspective, being that Kaiser's both a health system and a health plan, and that some of what he said earlier was very compelling in terms of using and knowing that it really is a good sort of predictor. And I wanted more about what Kaiser's done, in terms of interventions, or what data you have that may assist in this conversation.
Thank you. I have a couple of points I wanted to make. The first one is not really necessary, but I graduated from Stanford Med School and from UC Berkeley School of Public Health, so I'm fine with the game. Not conflicted.
On the game on Saturday, he switches his hat.
There are these schools like that. But, one thing I wanted to say, just as a general comment, I think if Doug was willing to do it, and we could get somebody from the writing group, from the AHA, I think it would be wonderful if there was a commentary in a high-profile place where a statement that comes out which kind of explains what the differences are in, you know, in a way that you guys can, whoever it would be, could live with. To explain it